So the neuro-oncology of women is really one of my major passions in understanding cancer and how it relates to the changes of a woman over her lifespan. And that has to do with not just hormonal changes, but different pregnancy states or prevention of pregnancy states, and then the postpartum state, as well as when we become peri and postmenopausal. All of those things not just change the potential to make a tumor more aggressive, but it also changes a woman's tolerance of chemotherapy and different therapies. This also expands across those who are undergoing gender affirmation, cross hormone exposures. And in those particular situations, we deal with patients taking on different hormones in the process. Yes, ma'am.
I'm so sorry to interrupt you. The
That's
audience
okay.
is only seeing your first slide. I think you might have to unshare and then reshare in your presentation mode, only for that reason. So I'm sorry
for that.
Keeping up with your talk.
That's a big important step.
There we go.
That would have changed the entire thing. So can they see? I didn't even unshare yet.
Well, we're still on your kind of
first slide.
Your working slides, yeah, but not in presentation mode.
Let me stop that then. I'm gonna share the screen and make it, tell me if that helped.
There we go. Yep. Perfect.
You see it different there. Okay, good. Yeah, thank you so much. Yeah, this was the problem here. And then do you see the screen where I have these medical illustrations of women pregnant, brain tumor? Okay, wonderful. So this is the neuro-oncology of women, and as I described. Some of the objectives we're going to talk about is to discuss the diagnosis, pathophysiology of leptomeningeal carcinomatosis. You'll hear this called as leptomeningeal disease, LMD, leptomeningeal metastases, LM. So people have a bunch of different names for it, but it's really a spread of a solid or liquid tumor to the leptomeninges. We're going to review some cases to help understanding how this presents and how we treat and surveil the disease. We're going to identify mechanisms by which to treat, and then define some of the opportunities to overlap with our hospitalists and my subspecialty. So the first case I'll start with, and I always start with this case, is one of the most impactful cases in my career. It's 44. This was taken right from her electronic medical record. A lovely 44-year-old female who's accompanied by her mother. Unfortunately, in our culture of medicine, which we have to work to change, when a woman, in particular, comes in accompanied by, a mother and then described as lovely, we sometimes are prepared to discount, a patient. As I worked in my last institution in the Department of Diversity and Inclusion, I worked to make sure that when we were starting to teach our trainees about cases, how important is it to start with 34-year-old Black male as opposed to starting with chest pain, as opposed to starting with 34-year-old male with chest pain. I argue that sometimes we change our differential in what we're going to search for when we throw in race or we throw in religion. 34-year-old Muslim male approaches with chest pain. You automatically start to change those things. And so I argue that sometimes how we characterize our patients may be an evidence of how we're going to guide the therapy, or how we're going to maybe sort of discount or misinterpret some of their presentation. Had back pain, had already been to a chiropractor, had been given steroids, and you know how long it took for them to get to the opioids for this patient. Fortunately, she did a self-breast exam, which, by the way, is no longer recommended to be done by doctors or by the patients themselves. But most of my breast cancer patients have identified their own breast cancer through self-breast exam. She went on to go do a mammogram, and they found this axillary, this mass. Her reproductive history: she started menstruation early. She had been on oral contraceptives for an extended amount of time, and she had already had 2 children, all of which increase her risk for breast cancer. The early menarche is the one there. So she had the biopsy. It was stage 4 triple negative breast cancer already showing up in her liver and other abdominal organs. She went on to systemic therapy and palliative radiation to her spine because that's what where her back pain was. So we knew that she had some spine bone disease. Because she was young, they did the BRCA genetic testing and it was negative. They did an early image of her brain after radiation, everything was done, and it appeared to be normal. So this was done after all of the therapies, were done. It is not recommended that it's done right up front. However, I argue if it's already gone through the rest of the body, I would do the brain MRI up front. After therapy, that looked clean. Her body looked nice and clean. All those bright areas were lowered on the PET scan. By May 15th, just 3 months after all the treatment was done, for 3 to 4 months after the treatment was done, she started having numbness, tingling, and twitching in her legs. And they presumed that was neuropathy and just put her on Neurontin. Several days later, she was in the ER in status epilepticus. This is her brain picture. It very likely was already involving her brain, but moving not to look at the brain up front because it's not a part of the recommendation. We missed that this may have been cleaned up a bit, and so the MRI looked falsely improved. I designed a protocol that is very standardized now for all of our leptomeningeal disease patients, both at my last institution, which still goes on, and the institution here. Whole brain radiation therapy in 5 to 10 fractions. Ommaya reservoir placement so that you can have access to the CSF fluid in an intrathecal chemotherapy. This patient went on to having a brain that looked like that to having a brain that looked like this with the Ommaya port placed into the ventricle so we can access. You can see here on the MRI, there was just one tiny spot left over. We hit that with radiation and the patient went on to have an image that looked like this here. We treated that spot right there with radiation. Over the next several months, 9 months, we cleared the CSF of malignant cells. Her brain imaging improved. You can see she became completely ambulatory. Seizures and pain control, not on anything outside of some as needed short-acting opioids. And unfortunately, as we continued to follow the patient, there became some further misunderstanding about what's going on. She came in to see me, felt the best she ever felt, had a routine MRI of the brain, and somebody noticed this. Now here's her Ommaya port. The track goes into the ventricle, and right there, you're getting a little bit of brightness, or that brightness. Here's another image of that brightness. It's not having an increased blood volume in that area. So there's not bright red and yellow in this area. And then there's a tiny bit of restricted diffusion, and you see this leukoencephalopathy that all patients who get whole brain and chemotherapy, they assumed that they told her that this was progression of the disease, stop the treatment, you're gonna die. They said that this is maybe infectious, and now there's been an infection proposed to her through her Ommaya port, and it turns out it was just disseminated necrotizing leukoencephalopathy, which sounds more terrible than it is, but the fact is that what we have is and we did the back work to figure out that where we were injecting the chemotherapy, it was sort of kind of precipitating right there around that port and causing that area to become necrotic, and it was showing up on the MRI. We realized that in the process of her getting her treatment, the institution found a different company to make a cheaper version of the methotrexate that we were using for the patient, and that cheaper version started to accumulate around the Ommaya port. We switched back to the original version of that because we have 4 patients show up at the same time with this, and we were able to get rid of that problem. So 1 month later, it was still stable to resolving, and we realized that was not the problem. She kept going forward with her treatment, but unfortunately, she was not allowed to be on any clinical trials. She came in with difficulty breathing, and they thought it may be a PE, and nothing, showed up. What they did see is backflow from her, one of the superior vena cava vessels backflow from the liver, and they realized that what she was experiencing instead was something called tumor microemboli syndrome. She was so effectively treated for her cancer that the cells, cancer cells are just really very powerful and very immortal, and not being willing to be defeated, decided to split into 1 million small pieces and float around the vessels and become microemboli. So it's similar, to a embolic event, but it's the tumor that actually microembolize. Some of the take-home messages for this particular case, and I know that I'm moving quickly, but I'll also deliver these slides to Veronica so that you guys have them. Take-home messages is some gaps in health literacy for patients, as well as some policy barriers. As I noted, it is the Gynecologic Society's recommendation that patients do not self-test because it causes hysteria when you find something, that you don't really think feels normal. And physicians are not encouraged to test and do these exams on patients when they're in the office. It still bothers me. There's a delay into detecting her primary disease that was breast cancer. There was a delay in consulting neurology, believing that, this is just neuropathy, whether it's a painful neuropathy. And any neurologist that's listening will understand that if it's a numbness neuropathy, you do not add Neurontin because you cannot treat numbness, you treat pain. And so in her case, that it was not even the question, it was more, just add the Neurontin. Miseducation about interpreting the images, which further led to anxiety for the patient, that this was progressing or infection, or, this Ommaya is terrible for you. They've been around for over 50 years. It's not something brand new. We just need to revisit how to treat those. And then the fact that she's excluded from any clinical trial for her breast cancer because of the fact that she has the diagnosis of leptomeningeal disease. Those patients, and I'll tell you about this a little bit later, but they typically, without any treatment, are dead within 4 to 6 weeks. And so nobody wants to include them on their clinical trials. I argue that with effective treatment, we can put those patients on clinical trials. Here's the second case. 58-year-old male presents to the ED with episodes of altered mental status. He recently visited Mexico, and he ate some food while he was there. And he had a history of prostate cancer, but that doesn't really go to the brain, and anybody can read about that. So, he did go to Mexico, and so it's neurocysticercosis, right? These are not his images. That's wrong. This was his brain image, and I could say, yeah, sure, maybe it does, but neurocysticercosis comes with the whole plethora of other findings that you get, and it's not within the 2-3 weeks after you visit Mexico and ate some of the food there. It's a situation where 9 months to a year down the line, those parasites will find their way into areas. So this was the brain presentation back in February of 2021. My first year here, I had just started in January, but I did not hear about this patient. They came to the ED. Someone suspected it was neurocysticercosis based on the history gathered, and they told him, just with his off and on mental status, this is a very pronounced MRI, and all the way up to the top of the brain, you can see these types of lesions, but it was mostly in the posterior fossa. He was sent out of the ED to follow up with his family doctor and maybe get an appointment with neurology, but none of that happened from February to March. He comes back in March, and this is now the brain. You can see there's more areas involved. At this point, he is in status epilepticus, and we get a call. They presented him immediately, at the tumor board, and they talked about the concern for cysticercosis. And there was such disagreement amongst everybody, just being twisted by the idea that he had been to Mexico, and the biopsy was completed. They determined that indeed his prostate cancer, because it was neuroendocrine, did go to the brain, and neuroendocrine tumors do like to find their way to the brain. His systemic disease was no evidence of disease. That's what they were saying. Now, if there's no evidence of disease, how do you get prostate cells in your brain? So that's one of my biggest sort of, pet peeves. But we went on they had a hospice discussion with the family, patient advocacy involved. Wait a minute, he came in February, nobody did anything. Treatment was initiated, and as he's trached, pegged, everything going on. 8 weeks he sat there, and I fought for this patient to continue to have the treatment, because he came in February, and he walked in with his family. They said just weeks before he came in with that altered mental status, he was taking care of all of his own ADLs, doing his regular life, working very effectively. We continued to advocate for him as he laid down for 8 weeks and got whole brain radiation therapy, followed by the Ommaya placement and intrathecal chemotherapy. And we continued his treatment until this point. And he woke up. And he woke up about 6 weeks into that trach-pegged situation, where I remember, he doesn't remember meeting me, of course, but I remember him saying, "How long has it been? Where's my family?" And we were able to, really continue working with this patient, continued treatment response. And then as I'm working with the outside medical oncologist to treat his systemic disease, the oncologist said, "No, his disease is only in the brain. There's nothing else going on." I said, in order to get prostate cells into the brain, they have to come from somewhere near where a prostate was. So it had to come from somewhere in the body. So even if there's no evidence of disease, those cells are leaving that cavity, that compartment in the body, to make it to the sanctuary called the brain. So the patient basically progressed off of any systemic therapy. I cannot maintain control of the brain if the spigot pouring the cells in from the body into the brain is there. Those cells get in the brain and they're hidden from the immune system. They're hidden from chemotherapies. So I urged the doctor to please put him on some type of systemic therapy, just for, just to see if something, worked for him. And indeed, they tried the systemic therapy that penetrated the blood-brain barrier, and this was his response to that therapy. You can see that he continued to have a durable response over the successive months, and to the point where the systemic therapy doctor really felt like, wow, this looks good. I don't want to keep him on this therapy for so long, and they discontinued the systemic therapy. There's persisting no evidence of systemic disease. Intrathecal therapy at this point really becomes futile, because these cells have now been trained to learn how to fight that medical therapy. And the minute you stop it, now they become a little bit more powerful. And you can see how shaky this MRI is. This is what an MRI looks like when somebody is they're moving around too much in the MRI machine to be treated. I could probably see that there's a little bit more leptomeningeal disease. There's no ways really to, sort of overcome this. And with this clinical picture, even I can't do intrathecal therapy with that type of movement, and the patient succumbed to the disease. We got 1.5 years of treatment into this patient, where he was up, walking, talking, joking, on his way to Hawaii, doing all kinds of things. And we were able to recover, a lot of his condition. But the issues in this case, and I think the real take home, is there was premature discharge and lack of a real plan, with presumptions being made at the initiation of this patient's visit. This is what I used to really advocate for. He just needs to lay here in the hospital on a trach and event. And, some of you may have been even involved in this case, but making sure that I advocate on the behalf of the patient. One, I knew what was possible with treating leptomeningeal spread of his disease and the brain parenchymal disease. But I also understood that if a patient walks into the emergency room and having had a history of being totally normal, that brain is likely recoverable if we get rid of the offending, sort of source. The delay in consulting neuro-oncology once again, and then the rush to judgment that hospice would be the next best thing. It's miseducation to me, in this particular case, and poor understanding of the guidelines that surround leptomeningeal disease and the treatment of the need for systemic therapy overlapping with brain-directed therapy. And I keep saying this, and it should really be, something that sticks in your head. You don't get breast, lung, prostate, colon pieces in your brain if the disease is controlled in the body. Those things don't belong there. They should not be there. Obviously, those cells are leaving that compartment at a rate that's so quick that even the imaging that we use can't pick up a great amount of cells in the body because why? Well, they're leaving and they're not staying there. Here's the final case that I want to talk about here. There's a 49-year-old female, triple negative breast cancer, initially diagnosed in 2016. So she had been doing very well treated and had breast reconstruction. Everything was going well. She was last seen in December 2021 with no evidence of disease or progression, but they did notice a thyroid goiter. She had a long history of epilepsy and had been on carbamazepine. She had an unruptured cerebral aneurysm and prior CVA. So all of these things happen when you have cancer. You know, the issue of having cancer, having these the risk for stroke and maybe the aneurysm that's not related to cancer, but this weird history of seizures. You know, when I investigated, it wasn't a long history. It started within about a year of this last visit. She was in, her usual state of health in September 2022. So even 9 months after this, and still been on therapy, she started having weakness and tremors. And then they started to notice shaking episodes and fine tremors and decreased appetite and all these sort of malaise and sickness type behaviors. They did a workup and they did the brain, spine, CTCAP, lumbar puncture, everything. They even biopsied her thyroid, and the path and everything was still pending on this here, but they were searching for anything. But they noted that the brain MRI did show some, of the spine and the cervical cord, diffuse leptomeningeal disease. They even noted that the lumbar puncture revealed malignant cells. Stop the presses. That's the answer right there. The CSF did show that the patient had carcinomatous meningitis, which is another way that they call leptomeningeal disease. The patient was transferred for further care. And even at the further care, they did the further evaluation and noticed that there was breast cancer and leptomeningeal disease. In all of this time, she was never even sent to a neuro-oncologist. So a neuro-oncologist doesn't just take care of brain and spinal cord tumors. We take care of people with cancer and neurologic disease. That's cancer neurology or neuro-oncology. And so I argue that getting somebody intimately involved in these particular cases. Noted said that she was triple negative for breast cancer. When I was involved, when they decided that they wanted to do yet one more lumbar puncture just to see whether or not these cells really were malignant, I said, okay, if I can't stop the move to do another lumbar puncture and start treating because we know that it's there, why don't you allow me to do an initial very strong assay to be able to determine exactly even the number of cells that are there and to see if those cells were the same triple negative cells that they were way back in 2016 when she was diagnosed. In order for cancer to progress and become more effective in the body that it's trying to take over, they have to learn how to mutate and they have to learn how to evolve and to beat out the tumor treatment that you're using in the body. So one thing they do is they go to the brain and the spine and they hide behind the blood-brain barrier. They further can hide behind the blood CSF barrier once they're into the brain. So even if a medication can cross the blood-brain barrier, it may not be able to cross the blood CSF barrier. So these cells are very tricky, very immortal, but you can see this classic enhancement around the leptomeninges and in and out of the fovea of the cerebellum. She had some bone disease, obviously, but this is the coating, the Zucker-Gus coating that you can see around the leptomeninges of the brain and spine. So here's where the cytology was positive, clearly. They wanted another LP. We added the Biocept assay. The assay detects even fragments of cells that had tumor in them. You can see here that, are you still hearing me okay? Because there's a loud background here.
Yep, we sure can.
So if everybody could just mute there, yeah, thank you. The tumor cells here, they detected 67,000 tumor cells that were there. And very important is that they were able to detect HER2 positive cells. So she's no longer triple negative. This opens her up to therapies that are directed at HER2 cells. So the triple negative case that was back in 2016 is now in a different compartment in the body, which means that those cells may have taken on a new picture. We were able to start her with whole brain radiation therapy, which with this many cells, 67,000 plus, I'm used to seeing about 100, 200, maybe even 800 cells. She has 67,000. This patient's CSF looked like milk when we took that out of her body. And she underwent whole brain radiation therapy, placement of an Ommaya reservoir for access, intrathecal chemotherapy, but now I added a HER2-directed therapy to target that marker on those tumor cells. What we were able to see is on the next cytology, they were just atypical, very likely malignant, but 96% reduction in the number of cells that was there. That was one treatment. That was after one treatment. This is somebody who I've just given her second treatment yesterday. This was the biosept analysis there evaluating her, and now those HER2 cells are not detected. What was interesting is when somebody reviewed this, they thought, oh, wait a minute, so she's not HER2 positive. And I thought, no, we've targeted the heck out of those cells, and now those cells are not detected in the fluid. We need to continue because those cells are still coming in from the body up to the brain. But I refuse to do any more unless she was on systemic therapy for her disease. Luckily, that was not even a problem. We were able to continue to treat her with a triple therapy that includes HER2 targeted therapy in the body. And then now those cells are not floating into the brain. But even if they are, I'm attacking those cells with HER2 directed therapy into the fluid. The take home case here is the delay. The issues were the delay to the belief that they had indeed detected leptomeningeal disease. Rely on the data. The gold standard is if they see a malignant cell floating in the fluid, period. Analysis paralysis, we call it. So delaying to consult the neuro-oncologist because you're still trying to analyze the situation, and indeed debate, you basically become paralyzed with action in the way of having action. Barriers to understanding that leptomeningeal disease these cells, when they move to a different compartment, will become a little bit more aggressive and they may take on new characteristics. In the case of this tumor, the new characteristic it took on was to its own, demise because it took on a targeted marker that would normally make the tumor more aggressive, but instead it made it so that we could target it with therapies that were available. The resistance to even trying some of the new assays. So even me using that assay that would prove to them beyond a doubt that there were cells there with markers, that type of science was somewhat limited. Here's the sad part. I just started treating her. She's had 2 treatments. She's up, walking, talking, doing her thing. The CSF today. So this was, like I told you, my second treatment. The first treatment, when I pulled out the CSF, you wouldn't believe it. It was the worst CSF I've seen, actually, as far as murkiness. It looked like milk. It was completely white, not see-through at all. Yesterday, when I treated her in the infusion clinic, for the Ommaya clinic, she had a clear CSF. You could see right through it. She will not be allowed to be on any clinical trial that's available for breast cancer patients. This is unfortunate. I'm in the process of gathering all of the data, which I'm going to show you guys. The goal, here in just a second, the goals for treating leptomeningeal carcinomatosis is not to save lives. Despite what we've been taught, doctors don't save lives. They all die in the end. All patients die, and so the fact is that what we do is we extend life, and the goal to extend it with quality is number one for me. So even if these patients are not going to live very long with leptomeningeal disease, it's arguable that by the time they're presented to me, even in status epilepticus, it may be too late to recover that brain. But I never fail to try if I realize that this patient hasn't been like this for months and months. And but the potential to return them to decisional capacity and stop any further neurologic decline is key for me. And if we can do those things, you allow a patient who would have died in status epilepticus with a family up in the air, not being able to say bye, to turning that patient back to somebody who can make decisions. Not every case goes as beautifully as we showed here, but at the same time, many of those patients, I'm able in one treatment to reduce the tumor cells by 90%. And this new technology, this new assay has been able to show that. And literally, I was on the phone with the physician yesterday who was treating her, and that physician was just blown away. And they were just very grateful that, okay, I'm glad that we took this step, and I'm glad, even I'm happy that we have this new assay that can help us with determining what's going on with those cells at the cellular level. So you gather your metrics. If you guys are out there doing anything that you feel like is making, a difference, and it's really not well assessed or evaluated, you want to make sure that you gather your own metrics. So before we opened up the Omaya Clinic, and by Omaya Clinic, I'm not saying I invented the Omaya, that was actually Mr. Omaya who did it. The idea that the clinic is designed to have a very systematic, approach to whole brain radiation therapy very quickly after recognition of the disease, followed by placement of the Omaya reservoir, followed by intrathecal chemotherapy that is targeted and directed with this assay that continues to show me how the patient is doing and how the patient is responding to therapy. So before this standardized approach in my hands, and so these are all just my hands, breast cancer, leptomeningeal disease, they lived about 20.4 weeks. Melanoma, 22.4 weeks, and lung cancer, 12.0 weeks. And these patients were somewhat treated on systemic therapies. Maybe somebody gave them an intrathecal dose here and there through the lumbar cistern, through a lumbar puncture. And but after the development of this particular clinic, you can see that the breast cancer, this is my median overall survival. So that means 50% of people are still alive after the 116 weeks. For melanoma, we were able to double the median life expectancy, but for lung cancer, it was very tough. And you'll see that lung cancer actually presents a lot of times at the time that it's already metastasized to the brain. So there's been a number of cases that I deal with lung cancer mets to the brain where we diagnose lung cancer after taking out lung tissue out of the brain. So this part here I save for the end just so that we can wrap up and you can just get this kind of quick understanding. We have about 25 minutes or so left. First described in 1870, leptomeningeal metastases. It is only the first manifestation of cancer in about 5 to 10% of cases. Like I told you, it's a very bleak survival if it's not treated. And even when you do treat it, that time kind of goes to 2 to 3 months. And that's because the treatment has never been standardized. It doesn't happen enough and the patients don't live long enough to have had like standardized trials where you can randomize a patient to one group versus the other and design optimal therapies. The incidence is quite low, as I noted. 70% of leptomeningeal carcinomatosis patients are solid tumors like breast, lung, melanoma, and in that order. What's interesting is that melanoma is, and I don't think I have a slide for that. Yeah, melanoma actually is not as popular as breast and lung, but the people who have melanoma are more likely than any other solid tumor to have it go to the leptomeninges or into the brain. And it has to do with its embryological, development of skin in general and its proximity to the brain. But lung and breast are very common. They're the most popular types of tumors, and that's why they make up the largest percentage of these tumors that go to the brain. Breast cancer indeed does not go to the brain early. Lung cancer goes to the brain very early, and like I said, could be at the time of diagnosis. So this goes late, this goes early, and it has the highest predilection to go to the brain. Leukemias, lymphomas, blood tumors are not very common. Brain primary tumor, believe it or not, is not very likely to go into the fluid from the brain parenchyma. But on autopsy, there was some studies that showed that up to 25% of people with cancer had it floating around in the fluid, or if they look at the meninges, they can actually see that there was a disease there. The 3 most common compartments. So usually in these cases, it's 1 out of 3 cases, it's stuck into a single compartment. In this particular patient, it was primarily the posterior fossa, but that's where we can see it very nicely on the MRI imaging. So it can be in the brain cavity, in the posterior fossa, or in the spinal cord or at the nerve roots. Usually we see hydrocephalus in these patients, and here's where my run-in with neurosurgery seems to happen, because when they see the patient with elevated intracranial pressures or hydrocephalus, the thought is place an external ventricular drain and let the patient sit there and drain that out. That's okay, you know, in the beginning, especially if it's an emergency. Not just if you see it, but if you think that there's impending herniation and the patient is going to end up in trouble, you place this external ventricular drain and you let this drain out to help relieve some of that pressure. The problem with that is if everything is draining out, you're not treating the tumor and you're not draining out the cancer cells. You're draining out some of the fluid, but the cancer cells are continuing to push in. I've been, you know, asked, you know, a number of times, just inject the, you know, chemo through this external ventricular drain and inject that into there. And I say, okay, well, it's a drain. And so I'm going to inject it in, it's going to drain back out. So that's not an option. Well, we can clamp it off for a minute and then you inject it and clamp it. And then, well, when you clamp it for just a little bit, I need it clamped for 72 straight hours because that's the amount, that's the half-life of, for example, methotrexate. So if you're going to clamp it for 72 hours, why is it in there? What we need to do is we need to treat the underlying condition that's causing the outflow tracts of the CSF to be clogged, and that's why the patient's having that. So it takes a little bit of time and some, you know, in a dance with the people who are trying to do their job and stop the hydrocephalus that would kill the patient immediately. The problem is that I have to have this heart-to-heart with the family and say, listen, if they pull the drain and I start this intrathecal chemotherapy, there's a chance that I won't move as fast as the cells building up and the hydrocephalus may take her or him out. Okay, so that's a chance. But here's a guarantee. If you keep the external ventricular drain in, one, you'll stay in the hospital forever, you know, or for as long as the tumor, you know, continues to allow you to live in this particular setting, because you don't go home with EVDs and you don't go to even a sniff with an EVD. So the fact is that you'll have to sit here. The situation's not going to get better because we're not treating the cancer. And we're not going to allow them to internalize that drain and put it down into the abdominal cavity, which is another question that I sometimes get, because if the disease is primarily here, why would you shunt that disease back into the body? So it's a big, you know, issue, but we all have to learn ways to work together. And when I have this heart-to-heart with patients that, you know, either you keep the drain in and stay here and eventually the tumor will overcome you, or we pull the drain and start trying to do the job of getting rid of the underlying issue right away. Typically people will switch to that. And if I ever need that emergency support again, we go back to a drain temporarily and I change the plan and I go back in. But I don't typically give up, you know, with this until I know that there's just, it's futile. So it can be the spread of leptomeningeal disease can take place from at the level of the vasculature, so sort of spread around the spinal cord axis. It can get it perilymphatic as well, and those kind of move and get into the tissues, and then from the tissues that this lymphatic drainage has sort of, this is a good example of what happens in prostate cancer around the Bastion's plexus. So getting in and around those around the spinal cord and then hopping aboard vasculature and becoming a part of the leptomeninges. Direct extension, so you can have a cranial tumor there and somebody does surgery and cuts in and directly, you know, penetrates that into that layer, or it can touch down and become a part, you know, of the leptomeninges just from the bone surface that it's on. This is a nice little picture for you to kind of really imagine how it gets into those Virchow-Robin spaces and those areas that are not well covered by the blood-brain barrier, and watching it hitch rides along nerve roots and vessels here. I just think that this is a very nice depiction there. A study done at Memorial Sloan Kettering Cancer Center they just took a big series of 180 something patients, and they were able to show how the histologies of these patients and some of the characteristics of the patients, more women than men, you know, and there's probably something, you know, to be said about that. It probably has to do with the huge number of breast cancer, which can happen in men as well. But it really is interesting how a majority of my patients that I see are women. Median age, you can see that their functional capacity is, you know, relative. They need some support, you know, for the most part. And then having a history here of prior brain mets 70% of the time. So when you have a brain met, you really need to start looking, for some of those, and having active systemic disease is another thing. When I see leptomeningeal disease, I ask the question, where is the active disease? And even if you say no evidence of disease in the body, there's disease in the body, of course, because those cells are moving from their location to the brain. These are some of the common side effects I, kind of urge you to think about, when you see weakness, back pain, and you won't just see back pain. There'll be some other things, but you have to ask the patient about it. We've all learned how to say, oh no, my headache's not that bad. We've learned to ignore some of those things. It's looking for things that are evidence of cranial neuropathies, facial numbness. Numb chin syndrome is one of the kind of pathognomonic things we say happens in leptomeningeal metastases. The problem is that rarely happens, that somebody notices a numb chin. And even then, it's going to be a male typically who says, I was shaving and I couldn't notice something when I got to the part of my chin. Otherwise, who really notices that their chin is numb? So the diagnosis of leptomeningeal disease, you can't go by the clinical symptoms alone or the CSF analysis alone or the MRI alone. You can go by the CSF cytology alone, which is the gold standard. If those cells say that they're positive on the cytology, where they looked at these cells under the microscope and stained for them and they're positive, then there is disease in the CSF. Unfortunately, this is very high false negative, very high. As a matter of fact, I don't even count on it anymore. And if I see that it's positive, I'm like, oh, thanks. That saves me a lot of effort. But fact is that this is more times than not negative, unfortunately. What I have to go by is what I'm going to show you on the next screen. We're still using this old data here from 1998, where they say do 3 LPs to get that 90% accuracy. Truth is that I'm not going to put people through 3 LPs if I notice that some of the CSF analyses components that I'm going to show you on the next slide are positive and the MRI is looking positive and the patient has clinical symptoms and signs, of this, then I'm going to do one. I'm going to do a very effective biosept liquid biopsy of the fluid, and then I'm going to have my answer. So this is old data. People still use it. I don't. So looking at the lumbar puncture, this is the cytology I was talking about. When they see those cells and they're there, which is what they saw in my last case that I presented, that's the answer. Flow cytometry is more sensitive if it's a blood-borne malignancy and not trying to look at the biopsy tissue. So when we look at the CSF, if the protein is high, white blood cells are high, opening pressure high, you may or may not test that, but the glucose, here's the thing. The glucose, if you just look at the readout that they give you in Cerner and you look at the labs and it says CSF glucose normal, you cannot say that that is normal. It has to be less than 6, it's supposed to be 65% or more of what the serum value. So if somebody has a 100 glucose in their serum, they should have 65 glucose in their CSF. But if it's below that, if it's below 65% of what the serum number is, that's called low. So we can't just let them tell us that the glucose should be between 40 and 50. Fact is that it needs to be 65% or more, of whatever the serum value is. If it is not, something is eating up the glucose in the CSF fluid, and therefore it's either a bacteria or it's a neoplastic cell. So in summary, leptomeningeal carcinomatosis, it's increasing for several reasons. There's improved cancer therapies, keeping people alive longer. We have better diagnostic techniques for not just finding leptomeningeal carcinomatosis, but for also identifying brain metastases and even the primary disease itself. So patients are living longer, giving these cells longer opportunity to reach the haven that they need to reach, which is the brain. And even when they get there in this brain sanctuary, there is limited penetration of the systemic therapy. So we now have to be craftier with the systemic therapies that we design. The immune system is not very active in the brain, making it the haven. And the immune system not being very active there, we don't even have the immune capability to fight off a lot of these tumors once they get there. Not to mention, if this is a cancer patient, getting cancer therapies, we've already dampened their immune response throughout the body in general, trying to fight off the cancer cells. So it becomes the perfect place for these cells to be, except for when you find them at that location and you start targeting them there. And that's what I argue that we need to be able to do more effectively. We need more agents that penetrate the brain at the time of the diagnosis of the primary systemic cancer. We need to improve our communications within our subspecialties. I'm in the process of writing a book right now with a neuro-hospitalist, and it's called Neuro-Oncology for the Neuro-Hospitalist. And it's a case-based, expert annotated guide, reference manual for people on the floor in acute care settings to know sort of what to see and what to expect. So cases that are impactful just like these, we will go through some of those cases. And I think that it was an awesome opportunity for us to make something like this to show that we have to work together. So we have to improve how we standardize the care for leptomeningeal carcinomatosis, and we need to allow these patients to go on to clinical trials. I always talk to my residents when it comes to this last feature here. So value, being of value is so important. And when you are valuable, you have to understand that being valuable is not the same thing as being valued. So when you are at an institution, you start working, this is what you don't get in medical school, this is what they don't tell you in residency, that you can be very valuable in the things that you offer an institution, but it doesn't mean that you're going to be valued necessarily. You have to work to maintain your metrics, and not the metrics of how full your clinic was that day or how many patients did or did not show up, or what your RVUs are. What you really bring to the institution in the way of innovation, patient satisfaction, patient care, survivability, because the longer the patient survives, the longer they're going to be there draining money into the system. So the point is that I care about their survival for other reasons, but you have to understand what's valuable, in a particular institution, and that's everywhere you go. Don't look at the dynamics of one place and say, boy, I don't want to stay here because this is what's been going on. I heard Dr. So-and-so talking about this. Fact is that it's everywhere. You won't escape that. What you can do is make sure that you are valuable and then demand to be valued. Your worth should be a function of the value that you add. And so for more value that you add, there should be more worth, right? This is what you're worth. Your promotion and pay should equal your worth. Those are the things you need to fight for. And you only get that if you negotiate that on this side of the table. So I do a very, extensive lecture to my residents and my medical student trainees. And arguably, it's something that we need as physicians, and practicing, attendings. But I do this to show you exactly how you can demand those things. And I have a very nice contract, and it's different from many other people's contracts, but it has to do with understanding that this is the same issue everywhere you go, and that I will not allow anybody to assign a value to me because I already know what my worth is. And so when you demand to be valued based on your worth, that's where you sort of get satisfaction out of your career. Strive not to be a success, but rather to be of value. So I hope that this lecture has been of value to you, and I hope that you guys do reach out to me as needed. I'm only one person, and part of my getting some more value and some appreciation here is we're now interviewing another neuro-oncologist to come and help out a couple of the other locations. My goal is to have 2 more. So I want to leave this last 10 minutes or so, 7 minutes for questions. Thanks. Thank you very much. Oh, you're muted still.
I know. Thank you so
Okay.
much. I didn't need them hearing my clapping. My goodness, though. Thank you. Thank you. You're seeing some reactions here on the screen. I am going to open this up, so feel free to ask some questions or comments in the chat, and or raise your hands and we can call on you. I just wanted to highlight a couple of things that I really found so helpful. So first of all, being able to tease out some of the most important take-home points from each case, I think was very useful to all of us, no matter what our areas of specialty are. And I just wanted to highlight, mostly for the residents in the room, just thinking about all of the quality improvement principles that you heard in this talk today. So highly reliable interventions, creating a clinic that is dedicated to just this, just the management of these Ommaya ports alone was the, you know, had such an impact. That multidisciplinary approach to care, all of the ways building teams that are functional, all of those things was just so valuable to us in our daily work and in our you know, endless pursuit of quality improvement. So thank you so much.
Absolutely.
You can see some of the great comments of just words of appreciation, and of course to end with us all knowing that what we do every day is so valuable and meaningful and can really just helps create that sense of worth. It looks like, so this was a great comment by Dr. Knox, wondering, I think, how you figured out about that methotrexate generic, and then what efforts did it take for you to get them to convert back?
Yeah. So again, you know, thank you so much, guys. This is one of my favorite things. This is the best part of what it is that I do. And I've been mentoring a couple of students that are actually here. Still have students that I mentor, you know, and by student, I mean student of life, you know, so all of the physicians and the trainees and residents who are interested, I'm very open to that, just so that you know. But that's a great question. When I had 4 people and I was the only one treating, you know, these, and I don't let anybody touch my Ommayas. I was the only one treating. I knew that I had a standard way of approaching things. When I saw 4 people in a row show up with DNL, and I saw the flare up in the radiologists that were reading and the flare in the medical oncologists, and the patients were all concerned, I knew something had changed. My job then, as also a scientist, was to go back and see, I didn't change. I didn't change any of the equipment that I was using. They were still getting the same drug, but wait a minute, were they still getting the same drug? I went to the pharmacy and I asked them, and they said, yeah, we just switched, you know, to a new company here. And, you know, and usually when you switch, it's because somebody's saving some money, you know, and we found out that it precipitates too easily. And the minute it was injected into the port, it was crystallizing around the port and causing these patients to have that damage. And so right away, it didn't take much, because since I was the only one doing it, it was working, people were living longer. I just made a fuss and said, we have to switch back. Look at what's happening. And they did it, and I didn't have a single additional case. Cytology. What's the sensitivity of high volume cytology? I mean, you have to do it, you know, but the truth is that it typically is negative. The potential to catch a cell if the CSF doesn't look like milk is very tough. And that's why they say do it 3 times. Nobody's going to let you do 3 lumbar punctures. And we don't have to do that anymore. There's a way to do a liquid biopsy that even sees ruptured cells. So if a cell was there and it ruptured open, the cell-free DNA that is consistent with cancer, those cells can be identified. So being able to, you can see it sometimes on MRI, but that means there's probably a lot of cells there, but they can be stuck within the leptomeninges. They don't have to be free floating. So you can see it on the MRI, but that doesn't necessarily mean you're going to catch a cell on cytology. So those new lab methods have to do with that biosept liquid biopsy. So as residents, ask for that. And all of the boxes of it are in my office. Unfortunately, I need to get people to, you know, be ready to have them, but I don't want to just have them sitting out there willy-nilly. If you don't know the steps to use it, you know, this is what I'm teaching people. Protocols, algorithms. Yeah. So I'll be sending you a copy of this, you know, presentation too. I did leave my phone number and my email, you know, address there for those people to reach out. I'm hoping that I get more support in the way of having somebody to help me with consultations on the floor. I'll always do a virtual or verbal, you know, consultation, but I may not always be able to run up to the floor. I do have my partners in medical oncology, since I'm the only neuro-oncologist here, and for Banner. You know, all of the hospitals, 6 states, I get on different tumor boards, answer questions, but we need more neuro-oncologists. And I think it's very impactful. If you think about the statistics here in the United States, there are 5 Black women that are neuro-oncologists in the entire United States. That is, really, to me, it tells you just how few overall neuro-oncologists there are. But it's a privilege for me to be doing the work. I think that, the fact that you give me these opportunities to talk and teach the people here at my own institution and within the trainee, path is very important to me. So let's keep thinking of ways that we can, connect and help train.
Great, wonderful. Well, with that, we will just thank you again for being here, and thank you all this morning in the audience for today's remote talk. Stay tuned for next week. We will see if we have the room back or not, or whether it remains remote, but we are thrilled to see you all again today. Thanks so much. Have a great Friday.
Thank you, guys.
Bye-bye.